Yes, and I've always enjoyed being in Mombasa, partly because it's always good networking with all of us. And then, of course, the whiskey part is also very important. Today, we are discussing transplant, and without much further ado, I'll take you in the next maybe 16, 17 minutes through a study that we did at both Kenyatta and Aga Khan. Those are my names. We entitled it Kidney Allograft Function and its Determinants at 12 months post-transplant in Kenya. Those are my supervisors, Professor Joshua Kaima, Professor McLegal, Dr. Ngigi, and Dr. Sokwala, of whom I'm very, very, very proud of. There you go. Good. Right, so I'll just dive straight into the introduction is a bit long, so I would just want to dive into the allograft dysfunction at 1 year. Allograft function at 1 year is increasingly being used as a surrogate marker for late graft function. We now know that if someone has poor graft function at 1 year, this particular person has a poorer half-life of the graft at 5 years, at 10 years, 15, and 20. So it meant that the fact that you can use this for prognostication, oh, thank you. So it has a prognostic value and it corresponds with a lower GFR, like I talked about. Not only does it correspond to the lower GFR, but also it raises the probability of eventual allograft loss and cardiovascular death. So in this particular study that we cited, recipients who had a serum creatinine of more than 1.5 milligrams or equivalent of 132.6 micromoles exhibited a poor graft loss half-life. And that is what we used as a definition of allograft dysfunction in this particular study. So we know some of the factors that affect allograft function, and we looked at these within the study. Some of these factors can be donor factors, others can be recipient, and of course others can be surgical related factors and also institution factors. So the donor factors could include a pre-nephrectomy GFR. You already see us doing TTPA for patients, for the donors, to see how much function they have, and also to look at which kidney is performing better than the other one. Recipient factors like obesity, diabetes. When someone is when a recipient is obese, if they have diabetes, they have a shorter graft like half-life. Other things like HLA matching, which you saw earlier on. Ischemic times are very important, especially within the cadaveric programs. And of course, delayed graft function. If a patient gets delayed graft function, this means if they need dialysis within the first week, if they get AKI and need dialysis within the first week of transplant, then they have a poorer half-life. So the problem with allograft dysfunction is it is associated with significant morbidity and with an increased 1 year all-cause mortality. Even when you tell a patient, well, your creatinine is rising, the look you see on their faces alone can even put a dark cloud around your own heart. You know, it causes not only stress to the caregiver, to the patient, but even to the doctor as well. And of course, we know that it predisposes to allograft loss. And this will, of course, bring up issues of reinitiation of dialysis, retransplantation. Most of these things are very, very expensive. We do not know the burden of late graft dysfunction at 12 months within Kenya. And we hoped that this study would help us with that. So we aimed at describing kidney allograft function of kidney transplant recipients at 1 year and assessing the associated determinants at 2 transplant centers within Kenya. These were our objectives. Of course, the first one, the general one, was to assess the function and determinants of kidney transplant recipients. The specific ones wanted to describe the selected pre-transplant donor and recipient characteristics, because we know these, without describing them, you will not look for them as particular variables. To describe the frequency of kidney allograft recipients' primary diagnosis, we want to know most of our patients, what they have as their primary diagnosis. We wanted to describe individual kidney allograft recipients' serial creatinine. When you transplant someone, how do their creatinines move? Can we get a particular trend? To describe a frequency of selected peri and post-transplant practices that are around our centers. We wanted to determine serial function using EGFR. And then secondarily, if we could, we hoped we could compare the clinical characteristics and biochemical factors in those who had allograft dysfunction and those who did not have allograft dysfunction. Because when you find them out, then you're able to say if the patient has, you're able to look at factors that might be associated with allograft dysfunction. Then we hoped to describe the risk factors associated with kidney allograft dysfunction at 12 months post-transplant. When you describe risk factors, then you're able to stratify your patients and you're able to help them earlier and maybe intervene early for those who might look like they might get risk graft dysfunction. So it was a retrospective study. Good enough, we chose 2 sites because we wanted to get the numbers, but also wanted to see if there was any inter-hospital variability. These sites were chosen randomly, so there's a selection bias there. However, this was COVID times. This was last year. We could have done all the sites. That meant using many more people. It meant exposing many more people to COVID. And of course, the resources as a student, as you can imagine, were not very available. We looked at all the patients that transplanted at Kenyatta National Hospital and Aga Khan between 2009 and December 2018. We included all charts of patients that were transplanted and that had a documented serum creatinine, both at 6 months and at 12 months. Because if they had those, then we were able to assess them. We had to exclude patients who were transplanted from other centers, but on follow-up from Kenyatta and Aga Khan, because these patients might not have the records, we might not know what they did, and that would have been, you'd have brought up some bias of remembering and stuff. Of course, if someone died before 12 months, we excluded them because then we would not know what their graft function was at 12 months. Anything that caused graft loss by 1 year, we excluded those patients because we wanted to have a functioning graft, but with a dysfunction. So graft loss before 1 year, patients that underwent a graft nephrectomy, those that experienced primary graft failure, we excluded all of them. So those were our variables, as we talked about in the risk factors. We looked at, we defined the dependent variable as kidney allograft dysfunction of more than 1.5 milligrams per deciliter, which was equal to 132.6 millimoles at 12 months. The donor variables, like talked about earlier on, age, gender, pre-existing disease, smoking history. We looked at all of these within the files. The recipient variables, like age, gender, primary disease, HLA mismatches, induction therapy, drugs, even the surgical time, the post-surgical complications, we took time and looked at all of that. So this is how we defined, I think I'll just maybe look at maybe 1 or 2 or 3. One of the things I want to bring out is how we defined blood transfusion. So there is peri-transplant and there is pre-transplant. Peri-transplant blood transfusion is if you get transfusion within the transplant, within 1 to 2 weeks within transplant, and if you have used a leukocyte filter. If you haven't used the leukocyte filter, we classified you as pre-transplant blood transfusions, and so that we can have a difference on that. Dialysis vintage was looked at, duration of time in months from initiation of dialysis to transplantation. Another thing, yes, the duration of surgery was defined in hours, and this was the time from initiation of anesthesia induction and extubating the patient. So let's look at the results. What did we find when we look at all this? I'll look at the results and discuss, since I only have about maybe 5 or 6 minutes to go. We looked at 240 patients. These are the patients who are transplanted over a 10-year period at 2 centers. Unfortunately, due to missing vital information, people who died before 1 year, we were able to get 108 charts from Kenyatta. We were able to get 42 charts. At the end of it all, we got one. We have some members talking. Right. So of the 150 charts, when we looked at the characteristics, remember, we wanted to look at the baseline characteristics of the donors, wanted to look at the baseline characteristics of the recipients. So we looked at the donor age. Interesting, we had very young donors, fairly young, 33 with a range of about 28, 39. It is very common within Africa to have young donors because most of our programs, in any case, are live donation programs. It is rare to find that someone who was above 60 is donating. Most of our donors, like we were not aware actually, were actually males. So, males actually doing something good for this country, and we thank them. Interestingly, most of the males who were donating were actually married. I don't know if they were forced by their spouses, but we did not look into that. And of course, most of the donors were first degree donors, and we had a very good pre-donation nephrectomy EGFR of 96, which is in keeping with the guidelines of the KDIGO, who say below 80, you want to think twice. The thing that is covered by this is the donor kidney side. Most of our donor nephrectomies were left nephrectomies. So when it came to the recipients, we had young recipients fairly of about 36 years on average. Most of them were males, again, something about the male. And again, most of them were married. I do not know why marriage is coming up. Again, the recipients were mainly hypertensive and diabetics, which is most in keeping with most of our data of chronic kidney disease within Kenya. One thing I want to bring your attention to is the presence of right there, the presence of urine protein, about 95, so about a percentage that about something percentage of patients had urine protein. So when they are young, and most of them have urine protein, and as we shall see later, they were hypertensives. So this gets you wondering, maybe another diagnosis to wonder about is chronic glomerulonephritis. Most of our patients had a dialysis vintage of about 14 months. And again, they were with most of our patients who were normal BMI, which is a good thing. But we did have some who were underweight, of a fairly good percentage. We also had patients who received methylprednisolone pulse therapy, about what percentage is that? You can see, yeah, about 32%. So some of the patients were receiving empiric therapy, methylprednisolone. We wanted to look at the EGFR and how it moves through the months after transplantation. As you can see, most of the patients reach their good EGFR at 3 months. When I say good is when it seems when they stabilize at about 3 months. So it means by about 3 months, if your patient hasn't gotten a good GFR, they might not get it. I'm gonna rush through this. Again, we try to stage the EGFR according to stages in each of the patients, and at each of the times, we have the discharge, 1 month, 3 months, 6 and 12 months. Most of our patients are within grade 2. Most of our patients are in grade 2. A few patients in grade 3A, even as it comes to the third 6 and 12 months. The good thing is we have most of our patients in grade 1 and grade 2, which is a very, very, very good thing for us. So what happened when we reached, when we looked at the kidney transplant recipients with allograft dysfunction? First of all, the prevalence of allograft dysfunction was actually about 22.6% at 1 year. So a quarter of our patients actually do have allograft dysfunction within 1 year. And on bivariate analysis, we found that the male gender, the people who are married, again, marriage comes up, I do not know why. People who receive pre-transplant blood transfusion, people who received empiric methylprednisolone therapy, patients who had acute kidney injury in their first year, and if you had a high creatinine at 3 months, at discharge and 6 months, you are associated with kidney allograft dysfunction. What does this mean for us in practice? It means it could suggest, when you look at the male gender, when we looked at a study done by Dr. Kubo a few years ago in transplant patients, most of the patients who had uncontrolled hypertension were actually males. So could this suggest that these patients have uncontrolled hypertension and it is causing the allograft dysfunction? We do not know because we did not look at that in this particular study. Pre-transplant blood transfusion could, like Dr. Barasa was saying, could cause allosensitization and could cause maybe rejection. No wonder some of these patients did receive empiric methylprednisolone therapy. And of course, again, rejection can lead to acute kidney injury. Acute kidney injury can be caused by many things during the first year of transplant. No wonder it was associated with allograft dysfunction. For this one we talked about it already. Now, one thing I want to bring your attention to is we did compare the hospitals when it came to the outcome, aka graft dysfunction, and we did not have any difference of graft dysfunction within the hospitals. So a subgroup analysis was not necessary for this particular study. So this is the gist of the matter. The risk factors. Our study was powered. Our study was powered enough to look at the secondary objectives. We had an 85% power at about 150 charts. So we went ahead and did a risk factor analysis for our patient, for the particular charts. And indeed, we found out that if a patient had acute kidney injury within the first year, we defined acute kidney injury as a rise in serum creatinine 1.5 times from the previous clinic visit. So if you came with 110 today, the next day you came with 140, we would call that acute kidney injury. So any documented acute kidney injury in the first year had 13-fold increase in risk of getting allograft dysfunction with a p-value of 0.008. Another one that was interesting, we did not expect this, was a duration of surgery. Patients who stayed in theater for more than 3.5 hours. So we remember we said we are defining surgery time as from induction to extubation. If that took more than 3.5 hours, those patients were at a 5-time increased risk of allograft dysfunction at 1 year. This brings out issues to think about during the surgery. So I'd like to bring your attention to the other factors that were not statistically significant, but had very interesting adjusted odds ratios. The male gender. I do not know something about the males. We shall look into it. But the males, they are called that. In Uganda, we say abasaja. But the males were at had a fourfold risk, increased risk of getting allograft dysfunction in our particular study. And so was the patient who received blood transfusion, a 3 times increased risk of getting allograft dysfunction. A patient who received methylprednisolone therapy, which we normally use to treat T-cell mediated rejection empirically, had a 2-fold risk of getting allograft dysfunction. So this is something for us to think about as we are doing our care. So what did this study offer? So we were able to describe the prevalence of allograft dysfunction. We know about its burden now. About a quarter of the patients do have allograft dysfunction at 1 year. We now know the clinical parameters that are associated with kidney allograft dysfunction within our community. And these factors can be looked at, can be risk stratified in our patients so that we know this person is at a risk of allograft dysfunction at 1 year and we should do something about it. My time is done. We had a few limitations, of course, being a retrospective study and its shortfalls. However, we tried to use many centers so that we can have the numbers. And we also use some good statistical methods to try and use, try and reduce the risks of using missed data. So in conclusion, the study has shown that allograft dysfunction is present in about a quarter of our patients at 1 year. And some of the risk factors to think about is acute kidney injury and also undergoing surgery for more than 3.5 hours. These are my recommendations, and we thank those who are on that list, and we miss Dr. Were very